non-traumatic intracerebral hemorrhage constitutes about 10 to 15% of acute strokes. However, it has the highest case fatality, so approximately 50% of patients die within the first months. So all those breakthroughs that we saw for acute ischemic stroke in the past few decades, such as thrombolysis and thrombectomy, was not present for the treatment of ICH. So this breakthrough has never happened. And I think this is partially due to the fact that there is still a knowledge gap related to the hematoma expansion in these patients, and also of the post-stroke events, and particularly of post-stroke hemostasis events. Now, about the treatment strategy in ICH, in intracerebral hemorrhage patients, of course, there is a need to identify the reasons for why the hematoma happened, so the underlying mechanism. There's the need to stabilize the patients, there's an aggressive blood pressure control, and there's the need to correct the coagulopathy, so to achieve the balance of hemostasis in these patients. But from the point of view of hemostasis, there are a lot of questions which emerge in the treating physician. So there's the constant fear of the hematoma expansion. Of course, if the patient has had the hematoma due to an anticoagulant treatment, then there's a need for reversal. But what I would like to highlight now is the need for thromboprophylaxis at the same time in these patients, because this is quite a paradox, or it seems like a paradox. But in patients with who have intracerebral hemorrhage, there's a very high risk for venous thromboembolism. In fact, the risk for venous thromboembolism is about 7% within the first month or during the hospital stay, which is very high. And this risk is approximately 4 times higher than what is known for acute ischemic stroke. So these patients are in need for thromboprophylaxis. However, when it comes to chemoprophylaxis, this could be quite a dilemma in the clinical practice. First of all, due to the fear of the hematoma expansion. And secondly, due to the fact that there are no tools which would help clinicians to have this decision-making, whether and when to start the anticoagulation. According to the guidelines, there is an absolute recommendation to start an intermittent pneumatic compression from day one after the diagnosis. But also there's a somewhat weaker recommendation to start thromboprophylaxis by low molecular weight heparin or low dose unfractionated heparin. And this can be initiated after the first or second day of the therapy. But of course, also according to the guidelines, the risk for any hemorrhage and the risk benefit for the hemorrhage and the thrombotic event has to be weighed. But so this is what we would like to highlight here, that it's very difficult to judge this blindly. But today there are now some hemostasis tests which can be helpful. And based on some clinical parameters of the patient and also using some hemostasis tests, this can be potentially easier, and clinical decision-making can be easier that way. So such tests can be, for example, the thrombin generation test, which in our experience was very useful and is sensitive for the outcome of the patients. And also there are some other global hemostasis tests, such as the clot lysis assay, where also perhaps the dimer test can be also useful in this clinical decision-making process. Now, there are very few studies related to this topic yet in the literature, but we think that there is an urgent need to have more studies, and particularly randomized clinical studies, which would study this topic in order to have more patients who indeed receive thromboprophylaxis. As there has been a lot of papers where they showed that, in fact, very few percentage of patients with ICH, with intracerebral hemorrhage, receive chemoprophylaxis in the clinical practice. In a large US survey, where they screened over 30,000 patients with ICH, less than 20% of these patients received chemoprophylaxis. And moreover, even those patients who did receive thromboprophylaxis, the time for the initiation of low molecular weight heparin prophylaxis was delayed. So for the future, it would be very important to design studies in which clinical decision-making would be helped by not only clinical factors, but also by appropriate hemostasis tests. And this could help this decision-making progress to have more patients receive the thromboprophylaxis that is needed, and which is very useful for them, and is better for the survival of the patients.